Hello, everyone, and welcome to today's Veterans Pulse Check, Closing the Gap, Health Equity for All Who Served. I am Walidah Bennett, founder and executive director of the Multi-Faith Veteran Initiative, and it is truly my honor to serve as your moderator for this very special Veterans Day edition. Today, we pause to honor the service, sacrifice, and strength of our nation's veterans, and to continue the important work ensuring that every veteran, regardless of background, has access to health, wellness, and the support that they deserve. PIPIN, People Empowering People for Inclusion Now, is an organization designed to increase participation of underserved and underrepresented populations in clinical research by providing access to innovative high-tech and high-touch resources. Their work promotes inclusion, improves outcomes, and advances health equity for all people. The Multi-Faith Veteran Initiative, or MVI as we are often referred to, creates Community Hub where veterans and their families find belonging and support as they are transitioning from military service. By partnering with faith-based organizations and social service organizations, MVI strengthens neighborhood networks and ensures that no veteran is left behind, especially in under-resourced communities. PIPIN and Multi-Faith Veteran Initiative has come together to spark conversations that bridge research, community, and care. These veteran pulse checks are designed to highlight community expertise, elevate authentic voices, and connect veterans to the trusted resources and opportunities for engagement. I am pleased that today joining me for this discussion are two outstanding veterans that have worked tirelessly to ensure that veterans and their families get the services that they need. Reverend Dr. James Miles is a transformative leader with over 25 years of experience spanning public policy, theology, enterprise development, and applied behavioral sciences. As founder and senior executive partner of the Resilient Village Collective, a national hub for coherence-centered leadership and community resilience, he advances strategies that promote healing, equity, and systematic innovation. A former U.S. Marine and systems analyst with the Joint Chiefs of Staff, Dr. Miles brings discipline and systems thinking to his work in faith, health, and community sectors. He holds doctorates in public policy and administration and ministry, and is a certified heart math master trainer, trauma-sensitive coach, and ordained minister. Appointed to the Illinois State Health Improvement Plan Council, Dr. Miles is committed to aligning personal transformation with collective well-being, guiding communities towards their better self and a better world vision. Dr. Terrell Odom is a U.S. Navy veteran who was born in Chicago and raised in the Auburn, Gresham, Inglewood, and South Shore neighborhoods. He served in the Navy as a hospital corpsman. Currently, he is the director of the Office of Military and Affiliated Communities at the University of Chicago, and also serves as the chair of the City of Chicago's Office of Veteran Affairs. With over 15 years of experience in higher education, he holds a Bachelor of Science degree from DeVry University, an MBA in accounting from American Military University, a Master's of Public Administration from the Keller Graduate School of Management, and a doctorate in Educational Leadership and Administration from Chicago State University. Welcome to both of you.
Thank you. Good to be here.
Thank you, Ms. Walidah.
Thank you. So to begin our discussion, we'd like to level set, and I'd like for each of you to just share your thoughts on what health equity means to you from the veterans lens.
I'm going to concede to the good Reverend first.
Oh boy. So thank you, sir. Equity is about access and opportunity. What that means is opportunity for each veteran to be able to explore their fullest health potential while having barriers to access lowered or removed in the process of doing so. And that's just across the platform. So that's kind of the lens I like to use to keep it really simple, but relatively inexhaustible of what that means for me.
I'm definitely going to agree with the Reverend there. My definition of health equity would be, again, ensuring that every service member, and I'm going to add in there, regards to their discharge status or their gender or race or geography where they're located, that they have the access to care and benefits earned through service. A lot of the times, we tend to leave out those individuals who may have an other than honorable discharge from the VA. However, they may still have some service-connected disabilities that has stemmed from their service. So I definitely want to make sure we throw in the discharge status.
Absolutely.
Okay, so thank you for each of that. And Dr. Odom, with that, as you alluded to the healthcare status of veterans, can you talk a little bit about what are some of the biggest gaps veterans face when they're transitioning to the civilian world, and then maybe even also into the civilian healthcare system?
Well, yeah. For me, I would talk about how true equity, again, goes beyond the let's say identical treatment. So it means meeting veterans where they are, including the mental health, the social determinants, and even community context. I've been able to see both sides of the system, the VA side of the house as well as community care, whether that's private community care versus the care that the VA now authorizes for folks to do within the community. And some of the gaps that still there are more structural, in my opinion. I would say that it's more so navigating the benefits of the VA. I tell my students all the time that the VA is like a web, and that web changes with every single presidential administration, every single VA secretary that comes in. There's a lot of inconsistency in record sharing. That's been a problem between the Department of Defense and the VA for God knows how long. And I don't see it changing anytime soon. And then I would also add a lack of culturally competent providers. We come from various backgrounds, various demographics, and having someone who can resonate with you with those shared experiences is going to be extremely beneficial for service members and veterans as they transition out.
Dr. Miles, would you like to add to that, or can you think of an example that illustrates where the system succeeds or fails in providing equitable care?
Absolutely. So I do agree with Dr. Odom and the ideal just on the structure alone. There's structural issues that exist even if for example, referrals to private sources, even if they work perfectly. There's structural issues, for example, for our rural veterans, for some of those who have transportation issues, who are in dual care modes, where they're getting some of their care from the VA, some of their care through Medicare or something, because over 65%, over 46% of our veterans in Illinois are 65 and older. So this ideal of navigating all that have structural issues, process issues that need to be addressed. Now, one of the areas that the VA has done a good job of expanding, good does not mean perfect, but they've done a good job of expanding, is when they look at bringing in behavioral health and telemedicine. They have really expanded those platforms to reach more, provide more services through them, and have done it with a relative degree. It's upgraded that access and opportunity. Now, an example, I'll give a personal example from a little bit ago. As a veteran who gets services from the VA, in an emergency situation, I went to the emergency room and was having chest pains. And because of the nature of it, I decided not to ignore it. I go in, I show up, and the attending physician was going to argue with me about what I meant that I was feeling flutters in my chest. And the debate got so, I was like, I forgot. I said, well, he had me questioning myself for a second. And then I was like, that's what you call it. It's a flutter. That's what it felt like. But there is such a thing as he was like, what is a flutter? And now here this guy, if it had not been for the nurse who came in to intercede, and then they had a, what do you call a resident doctor who happened to be African American, and nobody else in that care team, the service, they kept me from just walking out. I wound up getting admitted, moved away from that position. I went back to report the experience because that should not be. And we're talking about veterans coming in for care, but wind up in the parking lot, whether they're taking their life or etc. I said, this is an example of exacerbating the situation. The person in charge, I allowed him to convince me not to form a formal complaint because he promised he'd take care of it. Now, in hindsight, I should have filed that complaint anyway, because that was a case where cultural competency as well as professional standards were completely violated. And whatever his issue um, was a problem. So this notion, that was a personal example that, and the way that was handled, because the concern was they had trouble getting emergency medicine doctors to come in and fill those shifts. And so this ideal of being able to staff it, provide the care, and make sure it's accessible and culturally competent. Could you imagine working with a female who's coming and the sensitivities there, or other situations where you get somebody who's that crass or myopic in their delivery? What would that do to care delivery and care outcomes?
Mm-hmm. So was this experience with the VA or an outside of the VA hospital?
I was in the VA in the emergency room at a VA hospital, and it's the VA hospital that had my records. So there was no excuse. I was in that system at that hospital and that doctor, and I went to see the people who were in charge of those departments.
So I know that Terrell, where you're situated at the University of Chicago, and I know you've done a lot of work in terms of connecting the military side to the civilian side. Can you talk a little bit about what the experience is within the hospital setting, the healthcare setting that you're at when veterans come in to access services? Where are the gaps, or how do they have the similar experiences? Because what we know is that there has been this move towards the privatization of veteran healthcare. And so what are the implications of that when you're talking about the civilian healthcare system?
Well, here at the university, we're fortunate at our medical center to have military providers that are parts of programs that we have here at the university. The biggest challenge within not just the university's medical center, but lots of medical centers throughout the country is the ability to accept VA healthcare. That tends to be the biggest challenge or the biggest gap, I would say, as it pertains to those services. And pretty much as the Reverend just mentioned, the cultural competency. So if you go to medical facility that is unaware of the challenges, unaware of some of the service-connected disabilities that veterans have, they tend to bundle them into every other single type of patient that comes into their facility. That has become a huge problem. I'll definitely brag about the the Road Home program at Rush. I keep saying Rush Road Home, but the Road Home program at Rush, which is a fantastic program. It's a fantastic collaboration between the VA and an academic medical center. I remember when that program was first launched, and I was, like, wait a minute, they're going to provide health care to the veteran, the roommate, the family member, etc. And they've done a fantastic job with this. So tons of universities and medical centers could actually benefit from learning what Rush does with its patients as it pertains to mental health. And Reverend, if I can, I wanted to add on to what you mentioned about the flutter. I myself have dealt with heart failure, so I know what a flutter feels like. And I would, try my best to explain it to that physician, like, I'm not going anywhere. And to your other point, the VA has gotten better in some areas. I just recently switched back to utilizing VA healthcare after many, many years because I've always had my own private insurance. And the VA was, again, as I mentioned, like watching paint dry sometimes. And the access to get in to see specialty care. It's almost like a gatekeeping instant where you just can't, book an appointment with cardio. Use cardio as an example. I went in to see my new primary care doctor because my primary care physician moved to a different state, so I had to establish care somewhere else. And I literally have my cardio appointment tomorrow with the VA, the first one. And again, I've been in heart failure since last year, and this has taken 7 months, if I'm not mistaken, just to get in to see cardio. It's taken me even longer to get in to see respiratory, which I'm not seeing until January, I believe. So I get it. Some of those gaps that the VA has in there, again, about way of giving veterans that access or that immediate access to these services, they need to do a whole lot better.
Mhm.
There's another area on the gap side. The VA has so many classifications
Mhm.
and qualifications for care. You almost have to constantly stay up to date
Hmm.
on what's approved and what's not, what classification are you in, what degree of disability or not. And
Hmm.
then the whole area, the VA has done a much better job of treating non-combat related
Hmm.
issues, so long as it's service related. It used to be, it was either you were in theater or not.
Yep.
And
Mhm.
anything that happened out of theater, oh well, sorry, it's too bad it happened. Now they do that, but it's added there's a the level of complexity in understanding how to navigate the system. I will say from when I first experienced VA healthcare, which would have been in the 90s, to now, they have really improved.
Hmm.
You know, and but it's there's still quite a bit there, and those are gaps, particularly for someone who may not necessarily be considered as savvy um, and understanding of all this, and it just feels like denial or confusion.
So considering the complexity of navigating that VA system, can you talk a little bit about Terrell maybe and or Dr. Miles, why are so many veterans underutilizing the VA system, and how can community play a role in helping to increase the utilization of the VA?
Reverend, do you want to
Oh,
take a
I'll defer to
crack
you on this.
at that? So can you repeat that last part for me, Miss Walidah?
So what role can communities play in helping veterans access their VA benefits?
Well, when you say community, you're talking everybody, or you're just talking about one specific community. I think that first needs to be defined. So when you say community, to me, I'm thinking those affiliated with the military affiliated community. That would be veteran service organizations, that be non-for-profits, that would be faith-based organizations, etc. There needs to be much more awareness around the resources that the VA provides. For instance, uh, the diet plan that they have for individuals that you can now access through the VA. I didn't know that existed inside the VA until I got to see my new primary care doctor at the VA. And she mentioned to me, hey, we also got this particular plan that you can go see, the VA just, get a good diet plan. I said, wow, nutrition. I said, I didn't know that existed inside the VA. I would also say when it comes to transportation, which is going to be a big one, I know the VA has done a much better job of, being able to provide support for individuals to get there. You can put your claim in after you've visited the VA, but what about those folks who don't have the ability to get there before the appointment? There used to be a program where the PACE van or person would be able to get Uber rides to the VA, and a lot of that has subsided since COVID has passed. But again, by way of the community, as a disabled veteran, you get free CTA and free PACE, throughout the city of Chicago. As a disabled veteran, you get half off, if I'm not mistaken, at RTA, which would include Amtrak and Metra. So the community needs to do a better job of making sure that the resources are made aware to the service member and the veterans and their families that are looking to utilize their care within the VA system. The collaboration again between the faith-based educational, it's essential to bring in veterans closer, to utilizing those services at the VA.
Mhm, mhm. And so then, I mean, and you raise an important question, particularly in terms of transportation. So when we think about geography,
Mhm.
urban versus rural,
Mhm.
race, gender, or socioeconomic status, how does that impact, Dr. Miles, how does that impact the access to care? And
Yeah,
and again, how can the community perhaps, and I'm speaking, more broadly, but certainly those that are in the veteran serving community assist with access to
Sure.
care.
There's two sides that can often merge, and that's perceived issues and actual, and how they play with it. So, for example, I was just looking here, 65% of enrolled Illinois veterans, so about 552,000 veterans in Illinois, 65% of those who are actually enrolled in VA care actually use it. So you're looking at that, and this ideal, I was trying to get the actual number. Here we go. The of women veterans is 10%. Um, they're in the Illinois snapshot. 46% are 65 and older. But now keep in mind, then we've got women, we've got minorities, then we have those who are younger. Now, a care system that needs to be able to meet those different needs and the nature of what is most dominant from each era of service. That is quite a bit on the care system, depending on your access, depending on your socioeconomic status, depending on your cultural moorings. If you don't feel this is being served, and or this wait time is, Dr. Odom was mentioned, that wait time is long, but your care need is short. Now you've got to figure out how to get in and get a referral. How do you even vet the referral? So, like, there's a good partnership between Hines VA and Loyola. So because of that handshake, a lot of referrals can take place in an almost seamless fashion. But if you have to come to another space that's not so finely tuned, then the veteran themselves has to be much more active. And some of the care team or social service and et cetera aren't necessarily up to date or up to par on each veteran's jacket or situation. So navigating that, doing it so the community can not only make clear what care providers are available and veteran friendly, because there is a gap with some care providers will take the case or they'll take the patient. They'll want the payment for that, but they really aren't culturally competent, on what that veteran, there's a worldview that comes with each veteran, and it's not exactly the same. Whether it's by service, by age, by service conditions, by race, gender. We're just now really just barely starting to peel the cover on some of the issues around gender. And as we know, we will quickly say military sexual trauma, and you pointed this out many times. It's not just women. What about the men? So understanding these things, the community can play a role. It's kind of like a health navigator, kind of role that could be facilitations, FQHCs, federally qualified health centers, and some of the other community anchored care providers can become a little more present and active in forming these relationships, to be able to kind of help those veterans who are unique to their communities and population actually get the service and therefore enhance health equity.
Dr. Miles, you make a fantastic point when you talk about the I call it veteran ready, that some of these places need to be veteran ready. And it's almost like everybody knows what a food desert is, right? So when you think about deserts for VA services, Northwest Indiana, prior to the center that they have out there, was a complete desert, which also incorporated the southeast side of Chicago. So a lot of folks had to travel from Northwest Indiana and southeast side of Chicago to go all the way down to Jesse Brown. And now you have that Auburn Gresham Clinic in my old neighborhood that was built on 76 and Halsted, right across the street from the police station. But still within that particular clinic, yes, there's general practitioners, but there's not a center specifically to women veterans. So what if women veterans, again, reside in Northwest Indiana and they have to travel all the way down to Jesse Brown? That access there well, the access is not there, I should say, for them to be able to get care within their community. And then we also need to consider, back when we served, Dr. Miles, there was the don't ask, don't tell policy, which got repealed, and now it's back in place pretty much without them saying that it's back in place. And you're going to have tons of folks who identify with the LGBTQ community being put out of service over this past year. And folks, who may have been receiving some type of hormonal care, et cetera, while they were in service. How do you continue that on the outside when they come out? When I can only imagine with this current administration that they may make changes to folks being able to have those types of services within the VA. So it's going to get even worse for other segmented populations of the veterans.
And you raised this interesting point, particularly with women, that I want to touch on just a little bit more before we move on to veteran engagement and clinical research. What are some of the unique barriers that women veterans, I know, Dr. Miles, you talked about the low percentage of women veterans that are actually accessing those care, and minority veterans face that are often overlooked. How do we combat that? What are some of those issues? Dr. Miles?
On the women's side, so there's 10% of that 552, there's 10%. So the low number means that it doesn't always get the attention, because they're going to go with the larger service. However, women having clinics, providers, and institutions who understand the impact of what some of the women have experienced in different service connected moments, being able to understand how that impacts their well-being and health, which is not always clear, period, in or out of the VA system. And then some of the other issues that are shifting now, Dr. Odom, I'd love to, there's an interesting exploration about the mental and social impact of this current climate, and how that shows up inside our relationships, our bodies, and therefore on our charts. And discounting that because it doesn't fit a fixed protocol, as you said earlier, just wrapping everybody up in a bundle. So being able to bring those things out and actually hear the women as they come in would be a starting point. There's no one fix that's going to do it all. Is it going to happen overnight? And it is, of those who are in just Illinois, that 10% who are actually showing up in the healthcare registry, how are they also advocating and challenging the system to look at this better?
Yeah. That stigma is always there as well with the women vets when they go there. I tell the student veterans here at the university all the time. I say that I remember, doing programming for women veterans for years back before it was popular, and I've experienced women vets going to the VA and people asking them, where's your hero, where's your veteran, when in fact they were the veteran there. That's real. That has happened multiple times, which has caused a lot of distrust, in my opinion, a lot of distrust with our women veterans utilizing the VA healthcare service. And when I talk about the stigma specifically, not that this is everybody, but it's a nice population of folks when women vets go to the VA, and let's say if they're going in, and again, this could be male or female, forgive me, when they're going in for sexual trauma, the stigma around that. The VA, no matter where you go in the VA, everybody's going to have that access to your records to be able to see what you've been seeing for at the VA. So again, how uncomfortable a person would feel talking about those types of things with someone if you're going to podiatry, right? And you're talking to podiatry about these things that happen to you under a different specialty that you're being cared for. A lot of that plays into it as well, not just with the women veterans, but I would say more so with the women veterans.
I'd like to correct the number I gave earlier. It's there's 247,000 veterans enrolled in VA care in Illinois, and out of that, only 162,000 are unique patients actually availing themselves of the care.
Okay.
So this idea that why have I enrolled but not really participated? We have all of these barriers and gaps that can help explain that. That's a significant delta between those two numbers.
So what this discussion really kind of highlights is that while the VA is making progress, there's still a lot of gaps that we need to be looking at in terms of access to care to level set the health equity for veterans, be they male or females that are accessing that system. And having said that, I can only imagine how that translates when it comes to clinical research. I mean, each of you kind of talked about your own personal health journeys. And we know that many veterans carry a lot of issues that oftentimes get overlooked, but what we don't hear a lot about is the research and the clinical trials, which help shape the future of medicine. And veterans are often, like other minority groups, underrepresented. So I'd like for you to, talk a little bit about how can greater participation of veterans in clinical studies improve outcomes, both for veterans and for broader patient communities. And I'll start with you, Dr. Miles.
So one of the things I'll start on a good note. The VA has actually done a much better job than some of its general counterparts in getting Black involvement in clinical trials. And so when we look at that, there's a sense that Black participation in VA trials is around 23.5% versus 15 being that same population being 15%, 15.8% of beneficiaries, equity overall. So of all those who enrolled in it, 23% have been self-identifying as being Black. So that's much better than the civilian space. However, you still see, and veterans also see the fact that they want to pass it on. That whole, battle buddy that the Army uses, or, this ideal of that kind of being in the space and the mindset drives that. At the same time, you'll still find some of the same barriers. Access. Do I have access to it? Is this trial comorbidities? There's a lot of veterans that comorbidities may exclude them. Then the fact that, as we already said, that over 65 plus, 46% of that 552,000 veterans in Illinois are over 65. What are all the other things that come with that aged population, like some of the younger? So the being able to make the trials accessible while still meeting the goals of the trial creates some natural challenges, and then some of them are structural in process. How do we reach access and nurture the relationship to make them available, whether it's transportation issues, cost issues, understanding, et cetera.
And Dr. Odoms, do you know of any examples of successful studies or programs that have included veterans in terms of the clinical trials?
Absolutely. I'll give you one that the whole world knows about. So as we know, veterans experience, it's extremely vital to the research area, especially in spaces like PTSD, of course, now toxic exposure, and just long-term outcomes of military service. The greater veteran population can improve general medicine knowledge, and that's both for the military and the civilian populations, given how the service impacts health over a lifetime. When you think about Vietnam, and before wars were televised, I mean, they were televised before, but they put the recordings to the back and nobody talked about it. But when Vietnam was recorded, and you had all these other community members, the Allied Health came in, the faith-based organizations, all that came in. How do you think we started addressing PTSD? Prior to that, it was shell shock was the term that they used. You had your uncle that was upstairs that was shell shocked, and nobody knew what it was about. They talked about the ringing in the ear, the constant stare, et cetera, et cetera. And I'll throw a selfish plug for one of my favorite movies of all time, Rambo. Sylvester Stallone was talking specifically about these things that were happening to veterans in Vietnam, and before a lot of other people actually started realizing that was the case. And to your point, Dr. Miles, when the VA started looking more at services for individuals who were not in combat and just had those stressors, that's what happened in the early 2000s when the VA system became so over flooded with patients who never had the ability to tap into that care before, which pushed those wait lines, several months in time for folks to be able to get that care. And again, unfortunately, the suicide rate was at that time, I believe it was 30 plus suicides a day for veterans. And one is just too many. But also, if you look at the first helicopter evacuation, where did it happen? In the military. They took everything from a military model and applied it to the civilian sector. If you think about the Navy corpsman, I'm going to use the corpsman as an example, an IDC, which is an independent duty corpsman. That role in the civilian sector, the physician assistant, was created specifically around the independent duty corpsman. So we've been doing research on the military and veteran community as it relates to healthcare since forever. And it just, for me, I would think it just needs to be a little bit more awareness. And again, the continued research, again, to incorporate other demographics into that research, as the Reverend just mentioned. People of color have now, again, on the military side, have been better positioned to do those clinical trials. I'll use a successful example that I have had. I have a skill bridge program here at the university. And I had an Air Force psychologist who came to do skill bridge with me. And while she was here, she actually conducted research with our trauma department. So while she was looking at support and services for individuals within the city of Chicago who experienced trauma, she also was looking at the provider burnout from the ER physicians, the trauma physicians, the nurses, et cetera, and being able to create a support system for those individuals, i.e. the military affiliated folks. And now that research can be taken back to the DOD and saying, hey, yes, while all these folks are out there doing all of these cases, they too also need that support. But again, we've been involved in the research, we being the military and veteran community, since the beginning of time. Just up until now, people are starting to recognize a little bit more.
And how can organizations like, Pippin and NVI really make research more accessible and transparent and culturally relevant for veterans and the broader community, for that matter?
Well, I would say put it in plain language, put it in terms that folks can understand. When Dr. Miles, I'm sure when people send out all these research projects, I get it all the time in my email. Hey, I'm having this particular research. You mind sharing with the students? And I'll go, hey, can you dumb this down a little bit? Not saying that people are dumb, but it's a terminology we use in the military. Dumb it down a little bit. You need to put this in the most layman terms so people can understand not just the work that you're doing, but the benefit of the work that you're doing.
Right.
And I think that message needs to be amplified within the community. And again, not just the VA hospitals. We could also, organizations like MVI and Pepin can expand impact by simplifying the participation and the access. So within your spaces, Ms. Walidah, I know you all the way from Wisconsin to the South Side, at all of your different partner sites, making sure that they have that information readily available to individuals who wish to participate in the research study to help better the community.
It's in our culture now, these kind of quick microwave bites of information given in ways that lead to action. Now, there's all kinds of challenges with that, but in this case, checking in with the VA, challenging the VA information network, as Doc is saying here, dumbing it down, not giving me a consent form, no IRB stuff, but just what is this about, and having a clearinghouse. These things are available. So it was 1,000 points. It wasn't 1,000 points of light. There was this. I got this whole pamphlet when I went over to one of the VA centers, and it was talking about all these studies. And then I started getting emails. It actually got to be a bit much, to be real candid. But getting that information out is such a great starting point. Then number two, finding who were the points of contact to start having some of the what if. Well, what if we did this? What if we found funding for that? And then to bring it, not just send our veterans from the community to the VA, but bring the VA into these kind of contained spaces in our communities. And then as community organizations, MVI, Pepin, and others, just to start that process. For example, the work that you're doing at MVI helped raise the understanding of moral injury. A lot of people had no clue that PTSD wasn't the only game in town to try to figure out what's this moral injury thing that looks like it, but not. Raising that, just like MVI started doing that, there are other understandings, other opportunities where the VA can come into the community, and it doesn't have to be big cost. You know, it could just be an exchange of information that could lead towards unique partnerships where the community can own the process and the data and therefore help inform the use of it.
So it sounds like the through line from what we've heard from the discussion thus far is really how we raise awareness, how we push organizations that are in the community and veteran serving organizations to raise the awareness, connecting veterans, whether it's connecting veterans to the VA, whether it's connecting them to local neighborhood clinics or hospitals within the VA, but really raise this awareness of the individual uniqueness of veterans and the very specific culture of veterans and how that presents itself in the healthcare environment, which really then leads me to as we're approaching, our closing, veterans have always been these powerful advocates, right, for each other and for the nation. So when we talk about, we've talked about health equity and what that means within the veteran space. But what does advocacy for veteran health equity look like today, particularly in this climate?
I'd like to bridge the last question with this one in one way. The imagine that in a set community, so for example, in NVI community sites, a researcher loves having a population to look at. One of the things about these community sites is that they not only serve the veteran, it might give implications for National Guard groups. It could give so many implications for other ways where there's community-centric bodies of people who are connected to the service, in one way or another. And what is some of that's where we get the social determinants. What is some of the factors that influence well-being, health, seeking health, becoming more of an agent in my own health, overcoming or transcending traditional barriers as a partnership, not just an acquisition of another patient group so I can put a ticket on. So there's a sense in which advocacy, both bottom up and across, as you say, those through lines, could really be a wonderful pursuit with that focus in mind, that we're not just trying to get access to this one thing or wellness check. We really are looking at shifting how healthcare is experienced and accessed and understood in these very segmented communities where our veterans already are anyway, aging in place for the older ones, as we know, 65 and older. Aging in place is happening across the entire country. Now, what does that mean? And how can the veterans with these groups of people who are veterans who have some sense of a common bond that may be able to broker new ways of exploring it that otherwise wouldn't happen? So those are just a couple of thoughts that are coming up to me, right here.
Dr.
So, yep. So for me, health advocacy in the VA healthcare system, so many things I could say about this, but we need to be more proactive versus reactive to the things that are happening within the healthcare system. A lot of that continues to happen and has been happening for decades. We need to address, as we talked about throughout this conversation, all the systemic inequities rather than waiting on crisis-driven reform. Empowerment for me would come through the education, the representation, and partnerships. We have veterans that are serving as peer navigators, advisory board members, and data stewards. And I'm going to throw one out there about the veteran service organizations. I'm a Legionnaire, VFW, et cetera. This is in no way, shape, or form meant to be negative about our veteran service organizations. They do a fantastic job when it comes to helping that veteran navigate their benefits and how to apply for disability compensation, but not so much by way of helping them or educating that veteran to understand that once you get the benefits, these are the other healthcare things that you can actually have access to once you've gotten your disability rating. So if you're coming to me talking about sleep apnea, yeah, okay, we could talk about a specific disability percentage that you could potentially get. But hey, here's what they're also going to provide you with, whether it be the CPAP machine. We could talk about the Inspire that they put under the skin if you can't tolerate the CPAP machine, how getting inadequate sleep contributes to the PTSD, how it contributes to the comorbidities that Dr. Miles talked about. That type of education within our VSOs should be extended. The training that the VA provides to VSOs does not go that much in depth. It's more along, again, the procedural routes of how to apply for benefits, what particular forms they should have. And again, I'm no way in shape or form saying that VSOs are medical providers, but at least having that basic understanding of where to point that veteran to be able to get that information, I think would be extremely vital for all of the veteran community.
And you know what, Dr. Odom, I 1000% agree. And then this ideal of maybe we can sharpen our thinking a little bit to say, now, once we get it, where do we want to go with it? To kind of to help anchor it in the community and not just have it be another highway cut through the community.
Yep.
Actually, somewhat decentralizes our building up of capacity.
Yeah, so I think that what you bring up is a critical part in terms of partnerships. And of course, that's what MVI is really all about. It's how do we create these meaningful partnerships that can create opportunities for access to care. When we started out the discussion by talking about how we don't want to leave any veteran behind, right? We also don't want to leave their families behind because they're a part of families. And what we haven't touched about, and maybe this is for a future discussion, is how do we support the veteran families that are caring for veterans that have these health issues that, oftentimes, I know, Dr. Odom, you started a caregivers program, and oftentimes we leave them out of the discussion. So the partnerships between the community, organizations, researchers, and veteran advocates, and then how do we ensure that veterans' voices are at the top, addressing these issues?
Well, you just talked about, the partnerships. Partnerships can model scalable solutions throughout the country. So if you're including the data, the resources, the advocacy, that becomes a sustainable program that can, again, be replicated throughout the entire country. When you're thinking about let's go back to the transparency and the empowerment, right? So you want to make sure, again, that you have representation of veterans themselves inside of the discussions. I'm going to use an example. I have a Veterans Restorative Justice project that I created here at the University of Chicago. This is a partnership that I have with the Cook County Circuit Courts as well as the Cook County Jail to support veterans who, unfortunately, due to service-connected injuries, whether they're diagnosed or not, have found themselves in the criminal justice system. Now, you have tons of veterans, again, that are arrested and charged and held on what we call crimes of desperation. If you get hungry, you're going to try to eat, right? And a lot of these folks have not had the ability to be assessed by the VA. And again, in some of those cases, they may not have a discharge that warrants them to have access to the VA. So what do you do for the folks that don't have that access to the VA? What do you do? The legislation, the federal legislation on the book, if a person gets arrested and they're detained for X amount of days, if they're getting disability compensation, that disability compensation stops and their family is now impacted because that veteran is in custody. Having that veteran's voice at the table is extremely beneficial. Now, I myself am a veteran, and yes, I love doing all things that help veterans. But that particular program, what I did was I went and found a veteran who himself was involved in the criminal justice system. Greg Sanchez, my assistant director. I stole him from California, tricked him to leave California to come here to Chicago. I don't know how you leave 70 plus weather to come to
Yeah, right.
negative whatever, right? But Greg came here to University of Chicago, completed a graduate degree at the Harris School of Public Policy, and then I hired him right after. He is what success looks like inside of that particular type of program. He has been in their shoes. He knows the challenges on a day-to-day basis when it's not between the hours of 9 to 5, what it's like to be able to, potentially reoffend or potentially go back into those dark spaces. So his voice, his experiences added to the conversation with the research, the data, the outcomes, etc., makes a much better picture for people to understand that this is a huge problem. This is not just veterans being arrested because they got behavioral issues. No, they have some underlying issues that are there. And again, as you mentioned, with the comorbidities, I've had veterans who have other health conditions, but because of they're under the care of another government entity, i.e., the county jail, they can't get the services that they would otherwise get with the VA. Let's say I'm just going to use sciatica as an example. Veteran has sciatica and he typically gets muscle relaxants or maybe even shots. He doesn't get that now because he's locked up within the county jail, and the county's not going to spring for to through their agreement with whatever medical provider they're using to pay for those shots for you, to pay for these things for you. Even with the healthcare, they may not have all the medications that you're on. So all these things fit together, but the veteran voice inside of the conversation is going to be the most beneficial, and especially those with those lived experiences.
Yeah. So I think that is why we started these pulse checks. We really want to lift up the veteran voice. We want to hear from them. We want to hear what their experiences are, and we want them to be able to lead the conversation so that we can work towards improving the systems that they are engaging with, be they the VA system or be they the private system. And then how we who are in the veteran serving space can be the conduit for how we're bridging the private system and the VA system so they work better collaboratively together. So
I'd like to throw
sure.
one thing in, William. And it just popped up. In all of this potential collaboration, actual collaboration, one of the things that the community can do is find out who the real champions are. And I'll give an example. As you know, I offer self-regulation resilience training that people pay thousands of dollars for, literally. Offer the training, provide. I went to a VA and I said, I will do X free. Our work was do a pilot. I went to their mental health space that owned the resilience training. I'll talk to the person over it, a licensed psychologist. She wanted the material, but did not want anything to do with me. The first was like, yeah. And then as it went on, I talked to other colleagues in that department, and they acknowledged that this is a problem with this particular provider. It's kind of a zero-sum type and want to control. And now I was offering it free. So there was not a cost. I'm a veteran. So again, there was like on so many levels, I'll work with your people in the room. I'm not trying to create my own thing. And so the idea of making sure we have champions in the system who are not just licensed providers, but also hearts and minds and compassionate and ready to work on this bridge building.
So I think that what you have given us is this clarion call as we bring today's conversations to a close, that we want to improve access for veterans in terms of not just general care, but also we want to take a look at the existing work that has been done research-wise in terms of healthcare and how any clinical trials we can push representation for the veteran population. We want to make sure that we are including the community broadly and narrowly in these conversations so that they can serve as information conduits to make sure that veterans that are in the community that are coming, particularly those that are coming into spaces like MVI and other organizations in the community, have the information that they need and that we can help them transition. And we want to also continue to make sure that we are highlighting and uplifting the veteran voice. So I want to thank each of you for this most inspiring conversation that we've had today. This is the first of many yet to come. As I said, this will be an ongoing conversation around veteran healthcare issues. So I want to thank you both, Dr. Miles and Dr. Odom, for your leadership in this space, for your service, and your unwavering commitment to the veteran community. And to everyone watching, I want to thank you for being a part of this Veteran Day conversation with us. We are honored, all of you who have served. We are honored to do this ongoing work, ensuring that every veteran has access to equitable care, research opportunities, and the community support that they deserve. And on behalf of Pippin and MVI, we invite you to stay connected for upcoming Veteran Pulse checks and join us in the future for a conversation. Thank you for joining us and have a good afternoon.
Thanks for creating a space, Walidah.
Thank you so much, Ms. Walidah.